Dr. Balaga here. I have another terrific God Knowledge Doc podcast for physicians and advanced practice providers, including physician assistants and nurse practitioners. You should find this podcast very useful in your practice. In this podcast, I will discuss the cardiotoxicity reported in the DESTINY-Breast04 trial in the New England Journal of Medicine on July 7, 2022. The article is titled Trastuzumab in previously treated HER2-low advanced breast cancer. The lead author is Dr. Shanu Modi from Sloan Kettering Hospital in New York. In this trial, Dr. Modi and her co-investigators found that targeting low levels of HER2 with trastuzumab was a superior therapeutic approach to untargeted chemotherapy in patients with low HER2 metastatic breast cancer. The risk of disease progression or mortality was approximately 50% lower, and the risk of death was 30% lower in the trastuzumab group than with the physician's choice of chemotherapy, regardless of the hormone receptor status. The National Cancer Institute grades adverse events in cancer trials from grades 1 to 5. Grade 1 is mild or asymptomatic or mild symptoms. Grade 2 is moderate or minimal, local or non-invasive intervention indicated. Grade 3 is severe or medically significant but not immediately life-threatening or hospitalizations indicated. Grade 4 is life-threatening consequences, urgent intervention indicated, and Grade 5 is death or related to adverse events. This document is available at the National Cancer Institute. In this trial, in the New England Journal of Medicine, they found that trastuzumab was associated with left ventricular dysfunction in 17 patients, which was 4.6%, that is decreased ejection fraction of grade 1 in one patient, of grade 2 in 14 patients, and grade 3 in one patient, and cardiac failure of grade 2 in one patient, and of grade 3 in another patient. One patient had initially decreased ejection fraction, then later had cardiac failure. On the basis of laboratory values of LVEF, grade 2 events occurred in 10 to 19%. 10 to 19% decrease from baseline was observed in 44 of the 371 patients, that is 11.9% in the trastuzumab group, and in 10 of the 172 patients, that is 5.8% in the physician's choice group. Grade 3 events, that is greater than 20% decrease from baseline, was observed in 5 patients, that is about 1.5% of the patients in the trastuzumab group, and in no patients in the physician's choice group. In an accompanying editorial, Sarah Hurwitz from UCLA, oncologist, said that there was a notable exception of cardiotoxic effects, and she goes on to discuss the findings which I just enumerated to you. And in her opinion, selection bias may account for the low incidence of decreased left ventricular ejection fraction because all the patients had already received previous HER2-directed therapy without the development of cardiomyopathy. She also discusses that difference in unmeasured baseline risk factors may account for the seemingly discrepant cardiac outcomes. To this point, the proportion of patients with anthracycline pretreatment was reported in neither trial. With more widespread use of non-anthracycline options for HER2-positive early breast cancer, she concludes that the proportion of patients with cardiomyopathy from HER2-directed therapy may be decreasing. Whereas, she says, the use of anthracycline agents for high-risk HER2-negative early disease remains standard, which has the potential to increase the risk of cardiac events with HER2-targeted approach. We as cardio-oncologists know that asymptomatic LV dysfunction has severe prognosis from the Framingham study. Tommy Wang and Dr. Wasson from the Framingham group reported that there is mortality associated with asymptomatic LV dysfunction, and most of them die of sudden death. In fact, in the MERIT CHF study, in patients with NYHA class 2 and class 3 symptoms, the mortality is due to sudden death and not due to LV dysfunction. Because we can measure LVEF, we tend to focus and monitor only LV dysfunction. And I would argue that patients who receive cardiotoxic chemotherapy should be monitored for sudden death in addition to LV dysfunction. In fact, the Danish group, led by Anna Banke as a lead author, reported that Trastuzumab was associated with a twofold increased risk of cardiotoxicity compared with chemotherapy alone, and these effects were seen as long as 9 years after patients received therapy. In an editorial in Heart Failure Clinics of North America, Dr. Jim Young from Cleveland Clinic and myself have argued that ejection fraction is not adequate and we may need more advanced techniques such as LV strain to monitor cardiotoxicity, and ejection fraction may not be enough. One could argue that both the FDA and the National Cancer Institute, conducting clinical trials with cardiotoxic chemotherapeutic drugs, should have a cardio-oncologist as a co-investigator to better monitor the cardiotoxic effects of cardiotoxic chemotherapy. In addition to LV strain, in selected patients, one could argue it's important to use cardiac MRI. And just as we approach the assessment of immune checkpoint inhibitor myocarditis, I would argue that any cardiotoxic chemotherapy trial should utilize cardiac MRI, including advanced techniques such as late gadolinium enhancement, T1 and T2 mapping, T2 weighting, extracellular volume fraction mapping, and cine imaging, so that we can target and find asymptomatic LV dysfunction, because asymptomatic LV dysfunction has a higher mortality. Our concern is that the oncologist will save lives with effective cardiotoxic chemotherapy, but down the road, many of these patients will succumb to sudden death and LV dysfunction, and we may be able to prevent this by early detection and early therapy such as beta blockers or SGLT2 inhibitors in those who have underlying diabetes. In fact, I would argue that the International Cardio-Oncology Society and the European Cardio-Oncology Society and other cardio-oncology groups should work with the FDA, the National Cancer Institute, and oncologists conducting clinical trials with cardiotoxic chemotherapy to better detect and identify cardiotoxic effects in clinical trials so that we can help these patients down the road.